Thank you very much for your invitation. I am very pleased to take part today of this very important discussion on hepatitis B burst dose vaccination and maternal screening for hepatitis B in Africa. As you all know, viral hepatitis B is highly endemic in resource-limited countries, and Africa accounts for about 60 million people chronically infected with the virus. In resource-limited countries, HBV is transmitted early in life, either from mother-to-child transmission, called vertical transmission, or between children later in life, called horizontal transmission. High maternal HBV viral load, often associated with positive HBe antigen, is a key driver of vertical transmission. In Africa, vertical transmission is less frequent than in Asia as compared to horizontal transmission. We believe that vertical transmission accounts for about 10 to 15% of the transmission of hepatitis B in Africa. And this is one of the reasons why vertical transmission of hepatitis B has been long neglected in Africa. However, even in Africa, it's extremely important to prevent HBV mother-to-child transmission for four main reasons. First, the earlier the virus is transmitted, the higher the risk of chronicity is. And secondly, as part of the Prolifica program, we have shown that the early transmission of HBV is associated with higher risk of liver complication. In other words, people infected with HBV from mother to child are at significant higher risk of liver fibrosis, cirrhosis, and HCC as compared to people contaminated later in life during childhood. Thirdly, our research group at Imperial College London has shown that more HBV transmission will be due to mother-to-child transmission worldwide. Indeed, infant vaccination scale-up will mean that in the future, a greater proportion of new cases will be observed among neonates, as you can see here in blue as compared to the yellow curve. And importantly, our research group at Imperial College London has shown as well that to achieve the WHO HBV elimination target, it is absolutely critical to control HBV mother-to-child transmission. Indeed, as you can see here in the orange curve, even if we scale up HBV vaccination to 90%, it will take years and years to achieve HBV elimination. But if we combine HBV vaccination scale-up and prevention of mother-to-child transmission, then we can achieve the HBV elimination by 2030. But as I just told you, HBV mother-to-child transmission has been long neglected in Africa. And one of my colleagues, Dr. Shimakawa, has even shown that in Africa, the number of newborns infected each year by HBV is twice higher than the number of newborns infected with HIV each year. So how to prevent HBV mother-to-child transmission? So since 1992, the WHO recommends universal infant vaccination. And this means 3 doses of the vaccine at the age of 8 weeks, 12 weeks, and 16 weeks. And this has been integrated within the API of most African countries. Since 2009, the WHO recommends the burst dose vaccination, which means the administration of the first dose of the vaccine within the 24 hours of birth to all newborns born in high endemic areas. However, the delivery of HBV burst dose vaccine is a real challenge, especially in resource-limited countries. So the global coverage is only 39%. It's 35% in Southeast Asia, but as you can see, it's much lower in Africa, estimated at 11%. To date, only 12 countries have implemented the HBV burst dose vaccine in sub-Saharan Africa. A recent systematic review and meta-analysis even estimated a lower coverage of hepatitis B burst dose vaccination, with an estimate at 1.3% in sub-Saharan Africa. So why this? There are many barriers to hepatitis B burst dose delivery. First, this poses many logistical issues. There is still a high proportion of births at home or in non-medical facilities, with a lack of outreach programs to cover the births outside the hospital. The delivery of the burst dose vaccine is also a challenge over the weekend, and the burst dose vaccination also requires a cold chain system, which is not really available in all remote and rural areas. There are also diverse sociocultural barriers, and for example, in some countries, there is no trust in the healthcare systems, with familial pressure to give birth at home rather than the hospital. The healthcare workers are not well educated enough on the importance of delivering the hepatitis B burst dose vaccination. And there are also a combination of political and financial issues. The Global Alliance for Vaccination and Immunization still does not provide the monovalent hepatitis B vaccine in Africa. So how can we improve the hepatitis B burst dose vaccine coverage? We could use a controlled temperature change strategies. This team from Australia has shown that using this system could really be cost effective and impact on the HBV related burden of disease. We could use a pre-filled, very friendly device called Uniject, pre-filled with the vaccine. And that could be used by, for example, community health workers to reach babies born in rural areas at home, for example. There is some microneedle patches of vaccines under development, but still not available. Probably developing more outreach community programs would be a good strategy to improve the HBV burst dose vaccine coverage. And improving education is absolutely critical. A study has shown that the poor awareness of the healthcare workers was associated with poor hepatitis B burst dose coverage, irrespective of the vaccine costs. However, what we know is the hepatitis B burst dose vaccination is not sufficient to control HBV mother-to-child transmission. In Africa, HBV mother-to-child transmission has been poorly documented. We know, but only from one non-randomized control trial, that the efficacy of the hepatitis B burst dose vaccine is good, but not sufficient to prevent the transmission. And in babies born to high viremic pregnant women, there is a residual risk of transmission estimated at about 38%. So if we look at the Asian triple model intervention, you are certainly aware of these two randomized controlled trials from Asia. They both have shown the excellent efficacy of the triple model, combining maternal antiviral therapy using tenofovir in high viremic pregnant women, combined to the delivery of the HBV burst dose vaccine in their babies, plus the HBV immunoglobulins. However, this triple model is not applicable in sub-Saharan Africa for different reasons. First, there is no routine antenatal HPV screening in Africa. The risk stratification based on viral load levels or HBV antigen seropositivity is extremely difficult to run in sub-Saharan Africa. First, to run an HBV DNA measurement, it's complex, expensive, it is not done in routine in Africa, and even doing a HBE antigen serology is not always easy in rural areas. And there are currently 3 point-of-care tests which have been developed for the HBE antigen, but the sensitivity is very low. And thirdly, there is almost no access to HBV immunoglobulins, which are very expensive and again requires a cold chain system. And finally, and that is absolutely critical, there is no evidence-based data for the use of antiviral therapy in pregnant women in Africa. So how to control HBV mother-to-child transmission in Africa? There are different options which probably need to be better evaluated, but it is certainly urgent to implement HBV screening alongside, why not, the HIV and syphilis antenatal services. We have rapid point-of-care tests for HBs antigen, which are very accurate and not expensive. Regarding the risk stratification, the use of the HBE antigen point-of-care test is probably not an ideal good answer, since they have a poor accuracy with a sensitivity estimated between 30 and 40%. The use of dry blood spots could be an answer. We could run HBV DNA using dry blood spot, or use the gene expert system, which has been really important for Africa. However, these gene expert systems are not available in remote and rural areas. So some groups have also proposed to treat all intervention, treatment as prevention, as it is done for the prevention of HIV, mother-to-child transmission, without doing any risk stratification. This has been proposed to be a cost-effective strategy in South Africa, for example. But again, all these strategies need to be evaluated in Africa. So to conclude, prevention of HBV mother-to-child transmission is critical to control the HBV epidemic. And even if mother-to-child transmission is less important in Africa than in Asia, it is associated with a high risk of liver complication. So it is extremely important to control HBV mother-to-child transmission even in Africa. We urgently need strategies that are adapted to the African resource-limited settings to improve the HBV burst dose vaccine coverage, but also to control HBV mother-to-child transmission and eliminate finally the virus. So we need to develop strategies to improve screen and treatment intervention for HBV infected pregnant women. So I would like to thank all my colleagues from all over the world, especially from the Gambia and Senegal, and all the partners of the Prolifica program. And I invite you to follow us on Twitter and Facebook, and to visit our website. And thank you.